Hello dear students, a very good evening to everyone. Welcome to today's part 2 session of 25 most important clinical based anatomy questions, where we will discuss remaining 13 questions of this series. Before we will proceed further, please do visit www.medicozcommunity.com to avail early bird offer for the students who are preparing for their next plan exam. Before we proceed, please do let me know if there is any problem with the audio and visuals so that we can proceed further. Okay. Now we will start with question number 13. Okay. I'm sorry for the mistake. This is question number 13. So start with the question number, that is a 26-year-old woman comes to physician because of painful paresthesia in her foot. Examination shows decreased sensation in the first interdigital space. The patient paresthesia are most likely caused by compression of which of the following nerve? So here we have to find out due to compression of which nerve there is the painful paresthesia in the first and second interdigital space. Okay, and the options are option A superficial peroneal nerve, option B sural nerve, option C deep peroneal nerve, and option D saphenous nerve. Okay, so these are four options here to find out which nerve is compressed here in first interdigital space, which is producing this painful paresthesia in her foot. Clear? Now if any one of you knows the answer, please do let me know in the comment box. Okay, so to find out the answer, we will see the nerve supply of the foot. So here you can see in the nerve supply of the foot, we have the dorsal and plantar aspect of the foot, and the dorsum of the foot we have the nerve, that is the this nerve you can see here, this is the saphenous nerve. This nerve here we have, this is the this nerve here, this is the sural nerve. Okay, and here we have, this is the superficial peroneal nerve. So on the dorsum of the foot we have these three nerves, including the sural nerve, the saphenous nerve, and the superficial peroneal nerve. There is one more nerve in this area, and the nerve is called as the deep peroneal nerve. Okay, so now we have these four nerves and they are supplying the dorsum of the foot. Clear? Now we will see the condition here. So what was the condition? There was painful paresthesia in the first interdigital space. So with the help of this diagram, you can say this is the first interdigital space here, and this first interdigital space is supplied by the deep peroneal nerve. Okay. Now the deep peroneal nerve we all know, as we have discussed this point yesterday. So deep peroneal nerve, it is a branch or it is a terminal division of common peroneal nerve. Yes. Now this deep peroneal nerve, it enters into the dorsum of the foot by passing deep to the extensor retinaculum. As soon as this nerve it enters into the foot, clear, it divides into terminal branch, medial and lateral branches. Now the medial branch of this deep peroneal nerve, it is going to supply this interdigital space which is present between the great toe and the second toe. Now we have the answer here. So the which nerve is compressed here? So we have the deep peroneal nerve in this condition, which is compressed here and causing this painful paresthesia in the first interdigital space. Clear? So this is the answer here. So the option C is the answer for this question. Now we will proceed for the next question, that is question number 14. Now the question number 14 is, infection may spread from the nasal cavity to the meninges along the olfactory nerves. as it passes from the mucosa of the nasal cavity to the olfactory bulb via, so we just need to find out the space here, we just need to find out the passage here from where the olfactory nerves they are entering into the nasal cavity. Okay, so once we have find out that route, it will be obvious through that route the infection it may spread here into the nasal cavity. Okay, now we have options here. Option A, that is the cribriform plate of ethmoid bone. Option B, crista galli. Option C, foramen cecum. Option D is superior orbital fissure. So now we have these four options here, and we just need to find out from all these options your olfactory nerve it passes through which area or which space. Clear? So for that we just need to see this diagram here. So here you can see this is the diagram, okay, which is showing the sagittal section of your head and neck. Here we have this cavity here which is the nasal cavity. Here we have the cavity which is the cranial cavity. Clear? Now the cranial cavity, we all know the cranial cavity is dividing into three parts. It has anterior cranial fossa, it has posterior cranial fossa, and it has middle cranial fossa. Clear? Now you will see just above the lateral wall of nose or nasal cavity, we have the part of cranial fossa that is called as the anterior cranial fossa. Clear? So we have anterior cranial fossa here. Now when we will see the structure of the anterior cranial fossa, it is dividing into two parts, the middle part and the lateral part. Clear? So the middle part is made up of crista galli, and by the side of crista galli we have the cribriform plate of ethmoid bone. So here we have this kind of appearance in the middle part of this anterior cranial fossa. Clear? So this through this cribriform plate of ethmoid bone, you can see here these olfactory nerves they enters here within the nasal cavity via this olfactory bulb, because the olfactory bulb it rests here by the side of this crista galli, and when the nerves they are arising from here, they will go to the nasal cavity and they will passes through this space here which is called as the cribriform plate of ethmoid bone. So now we have the answer here. Through the cribriform plate of ethmoid bone, the olfactory nerve can passes here within the nasal cavity. So if there is an infection here, so it can spread to nasal cavity to meninges along with the olfactory nerve through which space? Through the cribriform plate of ethmoid bone. Okay. Now we have other options here like superior orbital fissure, it is in the middle cranial fossa. Then we have foramen cecum, it is a blind foramen here. Okay, now we have crista galli, it is a ridge-like structure, no structure can passes through it. So we are left with the cribriform plate of ethmoid bone which is present in the middle part of anterior cranial fossa, through which the olfactory nerve can passes to the nasal cavity. So the answer is option A, cribriform plate of ethmoid bone. Okay. So now we have the another question of this session, that is question number 15. So the question number 15 is examination. A patient is examined in the standing position. So we have done the examination of a patient when he is in standing position. Okay, and the condition is he has left side pleurisy. Clear? Where would you expect the pleural fluid to gravitate down to? So we just need to find out when the patient is in standing position with the pleurisy on its on his or her left side. So we just need to find out the space where that pleural fluid will gravitate down. Okay, so we have options here. Option A, oblique fissure. Option B, cardiac notch. Option C, costomediastinal recess, and option D, costodiaphragmatic recess. Clear? So now we have these four options and we just need to find out the area where this pleural fluid will go when the patient is in standing position. For that we just need to see this diagram here. So this is the diagram which is showing the lung with its pleura from the anterior aspect and the posterior aspect. Okay, so here you can see these margins here. Okay, these blue color margins here, they are showing the pleural reflection. Okay, so what is the pleural reflection? The layers of the pleura, they fuse with one another, and this is the area which is not occupied by the lung. Okay, so the space is left here, and that space is called as the pleural recess. Okay, then we need to find out which recess will be there where that pleural fluid will go. So in a standing position, you can see here this space here, this very little space, it is called as the costomediastinal recess. Okay, at the lower border of lung, you can see this area, it is called as the costodiaphragmatic recess. Okay, now we have two more options here, that is the oblique fissure and the cardiac notch. Now we all know the oblique fissure and the cardiac notch, they are present between the lung, and that is divided the lung into the lobes. So that cannot be the area here. And then we have the cardiac notch. So here we have the cardiac notch here, and this is the cardiac notch which is present only on the left side of your lung. And just below the cardiac notch we have this area here which is the costodiaphragmatic recess. So the pleural fluid, it can gravitate here, but from here it will easily come here into the costodiaphragm because it is in a lower level. So what is the answer here? The pleural fluid, it can gravitate down here within the costodiaphragmatic recess. Okay, so this is the answer. The option D is the answer for this question, that is costodiaphragmatic recess will be the area where this pleural fluid will gravitate down from the left side of the pleurisy when the patient is in standing position. Okay, so this is our question number 15. I hope everything is clear to you. If you have any queries, you can ask me in the chat box. Okay. Now we will proceed for the next question, that is question number 16. So in question number 16, we have a condition here which is basically this is a procedure which is called as the pericardiocentesis. Okay, now pericardiocentesis, it is best performed by passing a needle through. So we just need to find out the space here from where you can insert a needle to take that excessive pericardial fluid out from the pericardial cavity. Okay, and the procedure is called as the pericardiocentesis. Okay, so now we have to find out the space here. So the options are option A, the 4th intercostal space, the option B, the 6th intercostal space at the left paravertebral border. Okay, option C, the 2nd intercostal space at the mid-clavicular line, and option D, the subcostal angle. So we have these 4 options here. So out of these 4 options, we just need to find out from which space we will perform this pericardiocentesis. Okay, so to see the answer, we just need to see this diagram here. Yes, if any one of you know the answer of this question, please send your messages in the chat box and your answer in the chat box. Anyone? Okay. So here we all know this is the thoracic cavity where you can see the right and left lung. Then in the center we have the middle mediastinum, which is occupied by the heart. Okay, now the level of the extension of the heart, if we will see the costal level, so the heart, it is occupying 2nd to 6th intercostal. In some books it is written 3rd to 6th. Okay, so we can consider this thing here. Now we just need to find out the space here. Okay, we just need to find out a safe space so that the needle, it cannot pierce the pleura and the lung. So basically we have to save the lung and the pleura here. For that we will go on the left side here, because on the left side we have this notch here which is cardiac notch. Okay, through this area you can directly approach the heart. Okay, so we will take the safe area here, that is, here you can see this is the xiphoid process, which is the lowermost part of the sternum, and on the left side we have this cardiac notch. So we will take this angle here. So this is our left costal margin, this is the right costal margin. So there is an angle here between the right and left costal margin. In the middle we have the xiphoid process. So this angle here, it is called as the subcostal angle. Okay. Now what is subcostal angle? It is the angle which is present between the xiphoid process and right and left costal margin. So we have two subcostal angle, one on the right side, one on the left side. To approach this pericardiocentesis, we will use the left side, and here the safe area is by the left side of this xiphoid process, just left to it, this area here, and at this point the angle is called as the left subcostal angle. Okay, so this is the area here where we will use this procedure, and this procedure is called as the pericentesis. Okay, pericardiocentesis. So what we will use here, the option D, that is the subcostal angle, especially the left subcostal angle. So this is the right answer here. We cannot take this option A here because the fourth intercostal space, if we will approach the fourth intercostal space either from the right and left side, there may be a chances that can damage the pleura and the lung. Neither this sixth intercostal space, neither this second intercostal space at the mid-clavicular line. So which one is the safe area here? This is the left subcostal angle, which we will use to take that excessive pericardial fluid from the pericardial cavity, which is called as the pericardiocentesis. So generally we perform this procedure here at the subcostal angle. Okay, so this is the option D, which is the answer of this question. Now we will proceed for the question number 17. Okay, now in question number 17 there is a condition here, a patient who has sustained a fracture to the middle cranial fossa following a fall from a height and might have any of these nerve injured except. So we just need to find out the nerve, okay, that nerve which is not in the middle cranial fossa here. Okay, so what are the options here? We have option, that is option A, trigeminal nerve, option B, oculomotor nerve, option C, abducens nerve, option D, trochlear nerve, and option E, hypoglossal nerve. Okay, so we have these 5 nerves here. Out of all these 5 nerves, we just need to find out which nerve is not the part of this middle cranial fossa, which cannot be injured here when there is a fracture in the middle cranial fossa. Okay, so this is the diagram of cranial cavity where you can see anterior cranial fossa, okay, middle cranial fossa and posterior cranial fossa, and we just have to focus in this area which is the middle cranial fossa here. And in the middle cranial fossa you will see it has these openings. Okay, from these openings various nerves and vessels, they are passing through, either they are coming inside the cranial cavity or they are leaving the skull. Okay, so what are these foramens here? Most anteriorly here we have a foramen that is called as the superior orbital fissure. Okay, posterior to it we have the circular foramen which is called as the foramen rotundum. Then posterolateral to this foramen rotundum we have the oval shaped foramen which is called as the foramen ovale, and here we have a foramen which is called as the foramen lacerum, which is posteromedial to this foramen ovale. Now we just need to find out the structures they are passing through these foramens, and that's how we can get our answer. Clear? Through the superior orbital fissure. The nerve and vessels, they are passing through the superior orbital fissure. So what are these nerves? Is there anyone who knows the mnemonic for this? Mnemonic for the structures passing through the superior orbital fissure? Because there are so many structures, they are passing through the superior orbital fissure. So there is a mnemonic for this. Anyone? Okay. From the superior orbital fissure, we have a mnemonic that is I slept one night and left for Tokyo. Yes, so this is the mnemonic here, where I stands for inferior ophthalmic vein, S stands for superior ophthalmic vein, O stands for ophthalmic, N stands for nasociliary, A stands for abducent nerve, L stands for lacrimal, F stands for frontal, and T stands for trochlear nerve. Okay, so all these nerves, they along with the blood vessels, they are passing through the superior orbital fissure. Now from the foramen rotatum, the nerve is passing, that is the maxillary nerve. From the foramen ovale, the nerve is passing, that is the mandibular nerve. And from this foramen lacerum, the internal carotid artery, it enters here within the middle cranial fossa. Okay, now we have got all the nerves, they are passing through these foramens. Now we will look into the options here. The trigeminal nerve. Yes, the first and second division of the trigeminal nerve, okay, that is passing through the superior orbital fissure, including that mandibular nerve which is passing through the foramen ovale. Then oculomotor nerve was there, yes, which is again passing through the superior orbital fissure. Then we have abducent nerve, which is again passing through the superior orbital fissure, and trochlear nerve, again it is passing through the superior orbital fissure. Now we are left with this hypoglossal nerve. Okay, now the hypoglossal nerve, it is a nerve which is passing through the foramen, which is called as the hypoglossal canal. Okay, that is called as the hypoglossal canal. Now this hypoglossal canal, it is present in the posterior cranial fossa on the anterolateral to this foramen magnum. So this is the area where you can find this hypoglossal canal, and through the hypoglossal canal, the hypoglossal nerve is passing. So the answer for this question is the hypoglossal nerve is the nerve here which cannot be damaged here in case of fracture of the middle cranial fossa. Okay, so this is about the structures and nerves, they are passing through the foramens of middle cranial fossa, and the answer is option E. Okay, I hope I am clear to everyone. Okay, now we will start with the next question, that is question number 18. So the question is, in a patient with cancer of the stomach who requires a total gastrectomy, the following arteries must be ligated, okay, except which? So we just need to find out the artery here in these options which cannot be ligated here in case of total gastrectomy. Okay, so the options are option A, that is common hepatic artery, option B, short gastric arteries, option C, the left and the right gastroepiploic artery, option D, the right gastric artery, and option E, the left gastric artery. Okay, I know the answer is very simple, and if there is anyone who know the answer, please message in the chat box. No, option D is not the answer, Suman Kumari. No, no dear, this is not the answer for this question. Option D, no, this is not the correct one. Okay, I'll tell you the answer for this. Before that, we will discuss the arteries they are supplying the stomach. Okay, now it is obvious the arteries, they are surrounding the stomach and they are going to supply the stomach. We have to ligate those arteries here. Okay, so here we have this stomach here. Now this artery here, this is the celiac trunk. I hope you all are aware of it. It is coming from the abdominal aorta. Okay, now this celiac trunk, it is dividing into three arteries here. It is giving three arteries here. One is this splenic artery, which is passing behind the stomach to supply the spleen. Okay, then we have this artery here, which is the common hepatic artery, and then we have this artery here which is going upwardly, that is called as the left gastric artery. Okay, so we have these three artery here. Now these, out of these three arteries, the splenic artery is going to supply the spleen. The common hepatic artery, it is dividing into hepatic proper and gastroduodenal artery. Okay, and here we have the left gastric artery. So this left gastric artery, one branch is going to supply the lower end of this esophagus, and one branch is going to supply this lesser curvature of the stomach, which is here. Okay, left gastric artery. Then we have this these arteries here which are present along the greater curvature of the stomach. Okay, and they are the right and left gastroepiploic artery. The left gastroepiploic artery, it is coming from the splenic artery, and this right gastroepiploic artery, it is coming from the gastroduodenal artery, and these two arteries, they will anastomose here at the greater curvature of the stomach. So we have gastroepiploic artery which is supplying the stomach. We have left gastroepiploic artery which is supplying the stomach. We have this left gastric artery, and we have this right gastric artery. Okay, so we have right gastric artery, left gastric artery, gastroepiploic artery, and right and left gastroepiploic artery. And again, from these right and left gastroepiploic arteries, small arteries are arising. They are called as the short gastric arteries. Clear? So we have got all the arteries, they are going to supply your stomach, and they are arranged along the side of this stomach here. So when we will remove the stomach in case of the cancer, so what will happen, we just need to ligate these arteries here. Okay, so now we will look into the options here. So the options are common hepatic artery. We all know the common hepatic artery, it is going to supply the liver. Yes, so there is no need to ligate this common hepatic artery. We need to ligate short gastric artery. We need to ligate left and right gastroepiploic artery, right gastric artery, and left gastric artery. So the answer for this question is option A, that is the common hepatic artery, which is after arising from this celiac trunk. Okay, this common hepatic artery, it is going towards the right side, because ultimately it has to supply here, and it will divide into that hepatic artery and gastroduodenal artery. So there is no need to ligate this common hepatic artery. Apart from it, we need to ligate all the arteries, they are here in the option, because all these arteries, they are arranged around the greater and lesser curvature of the stomach. Okay, so the answer is common hepatic artery, that is option A. Okay, so this was question number 18. Now we will discuss with the next question, that is question number 19. Now this is the question here which is related to the head and neck portion, that is the wound of the scalp bleed continuously. Why there is any, if there is any wound in the scalp, why there is that bleeding which is continuously occur? So the options are option A, the scalp is highly vascular. Option B, the blood vessels lies just beneath the skin. Option C, due to wound gap. Option D, the vessel's wall fails to retract. Okay, so now we have to find out the answer here. Out of all these four options, what is the correct answer for this question? Yes, you can share your answer in the chat box. Okay, for that we will discuss the layers of this scalp. So here you can see this is the diagram which is showing the layers of this scalp. Okay, so scalp has 5 layers. Skin is the first layer, then the layer of connective tissue, that is the second. The third layer is aponeurotic, which is also known as the galea aponeurotica. The fourth layer is the layer of loose areolar tissue. Okay, and the fifth layer is pericranium. Okay, so these are 5 layers here. Now out of all these 5 layers, you can see in the second layer, which is the layer of connective tissue, and here the connective tissue, they are dense. Okay, so that's why it is called as the layer of dense connective tissue. They are densely arranged here. So here you can see between this layer there are the arrangement of blood vessels. Okay, now in the second layer there are blood vessels present, and this second layer, it is filled with numerous amount of connective tissue fibers. Clear? Now what happened, the wall of these blood vessels, they are surrounded by these connective tissue fibers, and they are adherent to these connective tissue fibers. They are adherent to these connective tissue fibers. Okay, so what happened when these blood vessels, they will get torn? No, so the wall of the artery, that cannot be retracted, because the wall that is adherent to the fibrous layer or connective tissue layer here. So there is, due to that condition, there is profuse bleeding or continuous bleeding whenever there is any artery in the second layer that is torn. Okay, so now we will look the question again. So we were here at question number 19. Okay, so the wound, if there is any wound in the scalp, okay, so bleeding is continuous here. Why? Now I have mentioned the answer here already, that is option D. The wall of the vessels, they fails to retract. Okay, now all of you have understood this point here, because the wall of the blood vessels, why they are failed to retract, because they are adherent to the surrounding connective tissue fibers. Okay, so due to that, when these blood vessels, they will rupture, okay, the wall that cannot be retracted, and they will be open, and that's how there will be a continuous bleeding. So this is the correct answer here, option D. Wound gap, it is not the reason here. Okay, because the wound gap, it is related to that galea aponeurotica layer. Blood vessels lie just beneath the skin, no, that cannot be the reason. If the blood vessels are present beneath the skin and their wall that is free, so there are chances we can stop the bleeding by giving a pressure on it. Then we have the scalp is highly, yes, it is highly vascular, but that is not a reason of this continuous bleeding. So what is the reason? The wall of the blood vessels, they fails to retract because they are adherent to the surrounding connective tissue, and that second layer has dense amount of connective tissue. Okay, so this is the answer here. Now we will proceed for the next question, that is question number 20. Question number 20 is, malignant tumor of the trigone of the bladder spread to which of the following lymph node? Now we have to find out the lymphatic drainage of the urinary bladder, especially the area of trigone. Okay, so what are the options here? The option A, that is the lumbar. Option B, that is the sacral group of lymph node. Option C, external iliac only. And option D, external and internal iliac group of lymph node. Okay, so to find out the answer, we will just see this diagram here. So here you can see this is the diagram which is showing the urinary bladder here. Okay, the internal part. Basically this is the posterior wall, where you can see this is the trigone. Okay, and here if you remember, we have an artery here. The name of this artery is common iliac artery. The common iliac artery is dividing into external and internal iliac artery. Along the side of the external iliac artery, we have external iliac group of lymph node. By the side of this internal artery, we have internal iliac artery. We have internal iliac group of lymph node. Okay, and the lymph from this part it directly drain into the external and iliac group of lymph node. So there may be a chances here the cancer can spread through these external and internal group of lymph node. Now there are some more options in this question, that is the lumbar and sacral. The lumbar group of lymph node, they are not present here surrounding the urinary bladder, they are present in front of lumbar vertebrae by the side of abdominal aorta. Sacral group of lymph node, they are present in front of the concavity of the sacrum by the side of the middle sacral artery. Okay, so in between we have urinary bladder here, and the blood vessels, they are surrounding it, external and internal iliac arteries, and the lymph nodes related to them, that is the external and iliac group of lymph node. So external and iliac group of lymph node will be the answer here. So in case of malignant tumor of the trigone of the urinary bladder, the cancer, it may spread to the external and iliac both, not only external, because the lymph, it is also going here within the internal iliac group of lymph node. Okay, so the answer is external and internal iliac group of lymph node. Now we have next question, that is question number 21. So the question number 21 is, an infant was diagnosed as having hydrocephalus. Okay, it was determined that there was a blockage in the ventricular system of the baby's brain between the third and fourth ventricle. The blockage therefore must have involved the, so we just need to find out the area or the blockage where it is present here. So the options are central canal, this is the option A. Option B is cerebral aqueduct. Option C, foramen of Lashka. Option D, foramen of Magendie. And option E, interventricular foramen. Okay, so to find out the answer, we will just see this diagram here. Here, this is the diagram which is showing the ventricular system of your brain. Here we have this ventricle which is called as the lateral ventricle. This is called as the third ventricle. Here we have this ventricle which is called as the fourth ventricle. Clear? So this is the continuation here. So from the lateral ventricle, the CSF, it come here through the foramen which is called as the interventricular foramen. From third to fourth, the CSF, it passes through this foramen here which is called as the cerebral aqueduct. Okay, now we have two more options here, that is the foramen of Lashka and foramen of Magendie. So foramen of Lashka and Magendie, they are the foramen of fourth ventricle on its lateral side. So that cannot be the answer here, because we are talking about the accumulation of the CSF that is present in the third and fourth ventricle, and with the help of this diagram we can understand there is a communication between the third and fourth ventricle via this which is called as the cerebral aqueduct. So there may be a chances of blockage of this cerebral aqueduct, that's why the CSF is accumulated here within the third and fourth ventricle. Okay, so the option B is the answer for this question, that is cerebral aqueduct. Central canal, it is present in the spinal cord. Cerebral aqueduct, it is present between the third and fourth ventricle. Foramen of Lashka, it is a lateral foramen of fourth ventricle. Foramen of Magendie, it is a medial foramen of the fourth ventricle. And interventricular foramen, it is a foramen which is present between the lateral ventricle and third ventricle. Okay, but there is an obstruction between the third and fourth, and the communicating way is the cerebral aqueduct. So the answer is B for this question. Okay, now we have next question here, that is the question number 22. Now the question number 22 is, the danger zone of the scalp is recognized as which of the following layers? So again we just need to find out the layers of the scalp here, and we have to see which layer is called as the danger zone of the scalp and why. Okay, so now we have the options here. Option A, Galea aponeurotica. Option B, loose connective tissue layer. Option C, pericranium. Option D is skin, and option E is subcutaneous connective tissue layer. Okay, so again we will see this diagram here. Yes, so here in this diagram you can see we have 5 layers of this scalp. That starts from the skin is the first layer. okay, which has hair follicles and sweat and sebaceous gland here. Then we have a layer of connective tissue. It is a layer of dense connective tissue, okay. And then we have a aponeurotic layer. So this aponeurotic layer is called as the galea aponeurotica. It is present between the occipitofrontalis muscle, okay. Then we have another layer, fourth one, that is the layer of loose areolar tissue. And then we have a layer which is a pericranium, which is made up of fibers, okay. This is a fibrous layer which is covering the bone of your scalp. Then bone of your skull, sorry. Then we will see there is a layer, that is a layer which is called as the fourth one, that is layer of loose areolar tissue. Clear? So what happens, this layer of loose area, hence the fiber, they are present loosely here, they are arranged loosely here. So there is the ample amount of space to accumulation of the pus, and if the pus will get accumulated here in this area, okay, there may be a chances of spreading of that infection from one place to another. So what happened, through this area there is a vein which is called as the emissary vein, okay, which is a valveless vein which is connecting with the deep venous sinuses. Okay, so whenever there is the infection in this area, because this area has the arrangement of loose alveolar tissue and it has ample amount of space here, pus can easily accommodate here. So what will happen, through these emissary vein, the infection can spread into the dural venous sinuses, okay, because these veins, these emissary veins are the valveless vein. So this is the answer here, the fourth layer, that is the loose alveolar tissue layer, and I have mentioned the reason for this. There is one more layer which is containing the connective tissue, but the connective tissue, they are present densely here, so there is no space between the fibers, and their infection can be there, but it cannot spread from this area because it is closely packed or densely packed structure, okay. So this is the answer, that is the fourth layer, and the option B is the answer here, that is the loose connective tissue layer, okay. So the danger area of the scalp or danger zone of the scalp is called as the loose connective tissue layer, which is the fourth layer. Now we have the next question here, that is the question number 23. In question number 23, there is a condition, a patient develops a cavernous sinus thrombosis because of its relation to the sinus. Which cranial nerve might be affected here? So here we just need to find out the cranial nerves, they are in relation or related to the cavernous sinus, okay. And the options are option A, abducens nerve, option B, facial nerve, option C, mandibular nerve, which is the third division of the trigeminal, option D is olfactory nerve, and option E is optic nerve, okay. So out of all these options, we just need to find out which nerve might be affected here in case of cavernous sinus thrombosis, which means we just need to find out the nerve which lies in relation with the cavernous sinus. For that, we need to see this diagram here. I hope you all are familiar with this diagram. So this is the diagram of the cavernous sinus, and this is a dural venous sinus which is present between, which is present in the middle cranial fossa, okay. And by the side of the body of sphenoid, and in the body of sphenoid there is a structure which is called as the sella turcica. So by the side of it, you can see this is the cavernous sinus here. So cavernous sinus, it has boundaries here. This is the medial wall here, okay. This is the floor, this is the lateral wall, and this is the roof. Now here you can see between the walls and along this side of the wall of the cavernous sinus, there are so many nerves and vessels. So this is the lateral wall. There are so many nerves, they are related to this lateral wall of the cavernous sinus from anterior to posteriorly, okay. So most anteriorly there is a nerve, oculomotor, then we have trochlear nerve, then we have this nerve which is the first division of the trigeminal nerve, which is your ophthalmic. Then we have this nerve here which is the second division, that is maxillary here. Then here between the walls we have a nerve which is the abducent nerve here. Then we have an artery here which is called as the internal carotid artery. So all these nerves, they are present in relation with the lateral wall and the floor of the cavernous sinus. And now we will look into the options here. Abducent nerve was there, yes, and we have the facial nerve here, we have mandibular nerve here, we have olfactory nerve here, we have optic nerve. Now facial, mandibular, olfactory and optic, they are not related to the cavernous sinus. Okay, these nerves, they are passing through different foramens of your skull. They are present in the posterior cranial fossa and middle cranial fossa. The mandibular nerve is passes through the foramen ovale. It has no relation with the cavernous sinus. So what nerve we have studied here? The abducent nerve. So the option A is the answer for this question. So out of all these given nerves, the abducent nerve, it present in the within the cavernous sinus. It is related to the cavernous sinus. So there may be a chances your abducent nerve can be affected in case of cavernous sinus thrombosis. Okay. So this is the question number 23. Then we will proceed for the next question, that is the question number 24. Now in the question number 24, there is an 84-year-old woman suffers a stroke with paralysis of right side of the body. Neurological test shows that the intracerebral hemorrhage has interrupted the blood supply of the posterior part of the frontal lobe, okay, and the parietal and medial portion of the temporal lobe. Now, of which cerebral hemisphere? Left cerebral hemisphere. Now, we just need to find out which blood vessel is involved here. So, the options are anterior cerebral artery, great cerebral vein, middle meningeal artery and posterior cerebral artery. So these are the arteries, they are supplying the brain, okay, except this vein, great cerebral vein. So this is, we will rule out this option from this part, because the stroke, it is related to the artery, it occurs in the artery, it is not related to the veins. So option B is eliminated here. Then we will see the blood supply for the brain. So here we have the blood supply. Here you can see this is the middle cerebral artery here. Okay, this middle cerebral artery, it is supplying the frontal lobe, parietal lobe, temporal and the medial part of temporal lobe here. Okay, now the remaining area here, it is supplied by the anterior cerebral artery, posterior and the meningeal artery. They are supplying the meninges of the brain. Okay, so now we have answer here. The middle cerebral artery is the answer here, that is the option C, which is supplying the posterior part of the frontal lobe, parietal and the medial portion of the temporal lobe. Okay, so this is the answer here. Anterior cerebral artery, it will supply the anterior and inferior part of the frontal lobe. Middle meningeal artery, obviously it will supply the meninges. Posterior cerebral artery, again it is more posterior towards the occipital, and great cerebral vein, it is not here in case of a stroke. So we have the answer, that is the middle cerebral artery. Okay, now this is the important thing here, you just need to remember these points. Then we will proceed for the last question of the session, that is the question number 25. So a 64-year-old old man was diagnosed with an acoustic neuroma. So what is the acoustic neuroma? It is a tumor of 8th cranial nerve where it enters the temporal bone. Okay, what other cranial nerve might also be affected, since this nerve uses the same foramen with the 8th nerve in its course? So we just need to find out the name of the cranial nerve which enters into the temporal bone along with the 8th cranial nerve. Okay, so options are option A abducent nerve, option B facial, option C glossopharyngeal and the option D trigeminal. Okay, so we just need to see this diagram here. Yeah, so here you can see this is the anterior cranial fossa, this is the middle and this is the posterior. Between the middle and posterior cranial fossa, we have this bony part here which is called as the petrous part of temporal bone, and the posterior surface of the petrous part of temporal bone, which is directed towards the posterior cranial fossa. Okay, it has an opening here which is called as the internal acoustic meatus. Okay, so the facial and the vestibulocochlear nerve After arising from the brain stem, they enters within the temporal bone by passing through this foramen, which is called as the internal acoustic meatus here. Okay, so we have the answer here. The facial nerve along with the vestibulocochlear nerve, it passes through the internal acoustic meatus in the temporal bone, and then it proceeds for its own course to supply, to distribute the target areas. Okay, now the answer is the facial nerve here. So facial nerve, it passes along with the vestibulocochlear nerve through the internal acoustic meatus. So the foramens of the skull, they are very important here. Okay, we have so many foramens in the anterior cranial fossa, in the middle cranial fossa, and in the posterior cranial fossa. So we just have to remember all the structures passing through the particular foramens, and if you have these kind of questions in your exams, you can easily solve them if you know all the structures passing through these foramens here. Okay, so we have the answer here, that is the option B, facial nerve. It passes through the internal acoustic meatus along with the vestibulocochlear nerve. Okay, glossopharyngeal nerve, it cannot be the answer. Trigeminal, we have already mentioned. The trigeminal nerve, the first and second division passes through the superior orbital fissure and the foramen rotundum, and the mandibularis passes through the foramen ovale. Okay, then abducent, again it is passing through the superior orbital fissure. Glossopharyngeal nerve, it is passing through the jugular foramen, which is in the posterior cranial fossa. Now the only nerve is the facial nerve, which passes through the internal acoustic meatus here. So this is the answer for this question, that is option B. So now we have finished all the questions of this session. Okay, I hope you all have understood all the points, and you will use these points for your studies. And thank you so much, and all the best for your exams.